So it brings me to the next talk from Dr. Satish Krishnamurthy from State University of New York in Syracuse. I think sometimes we manage many things without not knowing the beginning or the end, and that is in some ways with CSF dynamics. We don't really fully have a good idea of its production or its absorption, and it's like having an elephant and feeling our way through the system and having our models. So it's a real honor to have Dr. Satish Krishnamurthy, who has done a lot of work on the CSF dynamics, to give us his talk on pathways of CSF drainage. Thank you, sir.
Thank you so much, Naren. I really appreciate your invitation, and thank you for this opportunity to present our work at this very important occasion and august audience. My task is to talk about pathways of CSF drainage, and I'm going to start a little at a different starting point, just to make sure that we are all on the same page. So brain is completely permeable to water, which makes it very difficult to understand unidirectional CSF movement, and even more difficult to understand water movement as the primary problem that results in hydrocephalus. Aquaporin channels and other channels freely transport water, and Peter Agre and McKinnon got the Nobel Prize in Chemistry in 2003, where they demonstrated that aquaporin families are available and present in the surface and in the depths of the brain, and the water movement is very free without any impedance to the ionic environment. So the only force that brings in water into the brain is osmotic gradients given the permeability of the brain. This is not unusual or difficult to understand if you look at the neural tube. Neural tube is a single cell layer organ in the embryo, and the neural tube enlargement is very critical to the formation of a normal brain. And this happens despite the neural tube being permeable to the water. And it occurs, as this slide shows, it's a picture from a paper by Lowry et al. The expansion occurs before the heartbeat starts. And building upon that, if you take the proteoglycans in the neural tube and you lyse them with an enzyme, you get uniform dilatation of the brain and the spinal cord fluid, and this results in hydrocephalus. And this was demonstrated in 1988 by Alonso et al. So we use these to demonstrate for in adult rats that hyperosmolar dextran infusion will result in hydrocephalus. This paper was published in 2006, and you can see the ventricular dilatation without any flow obstruction using hyperosmolar 10 kilodalton dextran. And the more you put in, the more hydrocephalus you get. The more dextran, the higher the osmotic load. And this was published in 2012. And ventricles also dilate within half an hour. This is very common to see osmotic shifts, and we have all seen it. And what is interesting is that at 30 minutes, all the osmolar values are the same, whether it's in the blood or the CSF. So if you're looking for proof of osmolarity as the driving force using osmotic measurements, you won't find it because the water moves really quickly. what we'll have is a macromolecular axis as a signature of that movement. And when we look at this picture on the right, we can see that there is with increased dose of osmolarity, you don't get at 24 hours post-injection, you won't get the ventricles back to normal. But at the lower levels, it comes back to normal. And this was actually being corroborated by other people, and the Croatian group by Klarica and Oreskovic have shown that compensated hyperosmolarity is a cause for hydrocephalus. So what we have just basically said is that macromolecules that cannot leave the ventricle. The small molecules also are osmotic drivers, but they can leave the ventricle, so they don't keep the fluid in the ventricle. So macromolecules are prime drivers of fluid into the ventricles. So pathways of CSF drainage, therefore, should be where the macromolecules are cleared. And there are many different ways this macromolecules are cleared. And the reason is, if you look at the synapse and the synaptic cleft and the reliability of neural transmission, it depends on the clarity of the extracellular fluid. And if this fluid is contaminated with other molecules, it's likely that it will impair the synaptic transmission. So to be clear in your mind is very important for survival, whether it's in the ocean or the jungle. So body has many mechanisms to remove the macromolecules. And Davson, one of the premier CSF researchers, observed that ventricles act as a sink. I think the sink is for extracellular fluid and interstitial fluid, and the ventricles are a common space. There are two very well described pathways that we knew coming into these experiments. One was the paravascular pathways, which were popularized by Reynolds, first published in 1985, and Otto Weller published many papers leading to paravascular and immunity, etc. And recently it has gained attention by a different name called glymphatics, starting in 2012. We'll talk more about it. And nasal mucosa and olfactory pathways were well elucidated by Miles Johnston. They've done some elegant experiments, which I won't go into more detail. And these are pictures from our ion dextran experiments, fluorescent dextran experiments, which we really demonstrate that paravascular pathways and olfactory pathways are also seen in our model. And in our model, we demonstrated that at 1 hour they're paravascular, but at 4 hours following the injection, they're actually in the cells of the blood-brain barrier. So glymphatics, the concept of glymphatics were elaborated by Niedergard. And if you look at the colorful panel, you can see this is from their 2022 paper, which shows that there is a fluid in the paravascular space. There is periarterial CSF influx, interstitial solute movement, and interstitial solute drainage. And if you look carefully, it is going to the sinus. This is no different from what Reynolds wrote in 1985 in terms of observations. This is a HRP that was used, and it was injected into the ventricle. The top part is the ventricle, and if you see the enlarged space, there is perivascular location of the HRP. The issue with the glymphatics is it still orients towards the venous sinuses as the primary site of absorption, and there is no clear site of clearance for the CSF. What we did and published in 2018 in Brain Research was that we co-labeled the slides with microglial stain. That's the red, and the fitsidextran was green. So you can see the co-localized dye here. And we looked at the elimination of the fitsidextran using spectrophotometry. And you can see that at 30 minutes following the injection of the fitsidextran in the ventricle, you had a peak in the serum, and a little later you had a peak in the urine. And this is a really fast transport. And I want to focus on how these macromolecules are cleared a little bit, and to go back to which vessel is clearing. You can see that we used MRI data to look at a pre-scan and a post-scan with a ion-labeled dextran, and you can see the small venules are the ones that clear these macromolecules. So I had shown you earlier that at 4 hours following injection, that the blood-brain cells are picking up the dye, but I also showed you that the serum peak is about half an hour. So there must be some other process that's in place other than blood-brain barrier and perivascular space that is extracting these macromolecules out of the ventricles. And you can see here, the top row is normal, and the middle and the bottom row are 2 forms of hydrocephalus. And we can see that in 35 minutes and 1 hour, 19 minutes, the second 2 rows, you can see that there is a pickup of the ion dextran on an MRI into the choroid plexus. And just to be sure that we saw it in the choroid plexus, here is a histopathology slide of these choroid plexus inclusion of the fitsidextran. You can see the dots. And we also looked at the decreased T2 values in the choroid plexus in response to the hyperosmolar ion dextran injection. Here is the green dip 35 minutes later, which corresponds to the peak in the serum. And even in hydrocephalic animals, 2 different kinds, you could see the dip in 35 minutes, which represents picking up of the macromolecules. And we found the dextrans to be in a wide variety of cells, including astrocytes, endothelial cells, microglia, etc. And also in neurons. This is a co-localization of the ion, the fitsidextran in the neurons. So this might be a surprise for some of us. At least it was surprising to me that all these cells picked up. But basically, the brain is trying to clear the macromolecules away from the extracellular space. We found the transport not just along the olfactory pathways, but we found it getting transported along the optic nerves. And here you can see the different timelines. This is this is 35 minutes, 1 hour, and 2 hour. And you can see the pickup of the ion dextran on the MR scans. And you can see these 2 are panels with microscopy showing fitsidextran label. It's transported along trigeminal nerve into the spinal cord, into the spinal nerves. And this is a really wide distribution using a hyperosmolar dextran injection. I'm going to switch gears. So basically, we have the paravascular pathways. There is olfactory pathways. There is transport across the choroid plexus. There is transport along the brain parenchyma and sequestration of this infused ion dextran or fitsidextran into the cells of the central nervous system. and there is drainage along the cranial and the spinal nerves, and perhaps redistribution of the infused dextran in the cranial and the spinal space. Here we wanted to show if macromolecules are the primary source of water getting into the ventricle, we wanted to see if this macromolecular transport is different between the normal and the hydrocephalic animals. So here we compared normal animals, the top row, with basal cistern kaolin model, which is the middle row, which causes a great deal of hydrocephalus, and the cisterna magna model, which is the obstructive hydrocephalus. And here we can see we did 80 scans in 20 minutes. First 8 scans were baseline, and then we inject the ion dextran, and this is a decay of the ventricular ion load based on the R2 star value on the MRI scan. And you can see, and we calculated the T-half, which is the half-life of this graph. It was 7 minutes for normals. And in both hydrocephalic groups, the half-life was tremendously increased to 20 minutes. And when you did the histopathology and look at the vessels, you could see not only the delay in the transport of the macromolecules was probably because of the accumulation of the injected dextran in the perivascular space. And you can see in both models of hydrocephalus, you have perivascular cuffing, as if these macromolecules were waiting to get out of the brain. And we have shown this in a genetic model, which is called a POMGNT1 knockout mouse, where you get hydrocephalus, and when you put in ion dextran or FITC dextran, you can see that the normal doesn't have any perivascular cuffing, but the abnormal knockout with hydrocephalus has perivascular cuffing. So we think it is a marker histopathologically that these dextran molecules are accumulating in the perivascular space. So who cares about all of this? These are all very esoteric and meaningless if you cannot use it to have a better form of treatment. So we found that we found an article that demonstrated that there is decrease in P-glycoprotein expression in a HTX rat, and those rats have hydrocephalus. And this has been well studied by other investigators. Not going to go into detail on that, but we wanted to see if we can knock out P-glycoprotein and get very severe hydrocephalus. And if we can overexpress, it should protect the rat from hydrocephalus. So we used this concept to perform experiments. We used a MDR1A knockout, which is PGP inhibited or knocked out, and MRP2 knockout, which is PGP enhanced, and compared it to normal. We used an intraventricular injection of autologous blood to create hydrocephalus. We got 7 Tesla. We used 7 Tesla magnet to look at the ventricular size before the procedure, 5 days, 10 days, and 15 days after the procedure. And we used the half-life to test whether we change the half-life on these animals. Here are the results. You can see the red is the knockout for P-glycoprotein, and the green is the knockout which produces more P-glycoprotein, and the yellow is the control. And these are all normalized to pre-intervention scan. So you can see that there is a statistically significant increase in the ventricular volume with P-glycoprotein knockout. And there is a relative protection for 10 days, but it doesn't completely protect on day 15. for P-glycoprotein enhancement. And we can also see that the T-half, what we did was, this is normal, the first one, and the yellow one is normal animals with intraventricular hemorrhage who get hydrocephalus, and that's the T-half is increased, and MDR1A is slightly higher, but MRP2 gets the T-half closer to normal without any intraventricular hemorrhage. We also went ahead and looked at the potential for this to be clinically relevant. We did a retrospective review of over 10 years with 4,588 patients, adult patients with hydrocephalus, and looked at the presence or absence of P-glycoprotein medications, both inhibitors and inducers. And here are the results. With the inhibitor, which is the red, there were 1,440, and the inducer was 142. We showed that if you're unexposed to P-glycoprotein, the presence of one or more of P-glycoprotein inhibitors will increase the risk of hydrocephalus by 3.2 times. So, although this is a talk about pathways of CSF drainage, it's very important for us to understand where the fluid comes from and where the fluid goes and what drives the fluid. And from our experiments, it's clear that it's the macromolecules that drive the fluid in and out. And we have further proof that we can manipulate the macromolecules by interfering with the efflux transport mechanisms and change the degree of hydrocephalus. For now, it is for the worse. We can increase the degree of hydrocephalus both in the experimental world, and if you look at the data very clearly, compounds like erythromycin and other cancer drugs can definitely worsen hydrocephalus. So we are excited to say that our work is beginning to yield results, and we may be at the cusp of getting to a place where we can actually medically manage hydrocephalus. One shout out to Professor Sinali's work is that we are biased in your favor. The small venules do go into the venous sinuses, and this agrees with all your observations that you might have. And I might actually look into venous sinuses in the patients with hydrocephalus. There are some acknowledgements. My department, a couple of foundations, including Reach Foundation, which has given me substantial support. This is driven by patients, and Department of Defense award that we just completed. Thank you so much.
Thank you very much, Dr. Krishnamurthy. It's really useful to understand what's going behind, because as much as we find treating surgically hydrocephalus rewarding, ideally, if you know the mechanisms, then we might at least treat some of them non-surgically, medically. So it's important to understand the pathophysiology of hydrocephalus. So if I could please ask Dr. Jallo to make comments and questions first, and then we'll go to Professor Deopujari and then to Professor.
That was an excellent presentation. I agree with Naren. I mean, finding non-surgical methods to treat hydrocephalus is the goal. I think that would be the future if we could do that. The question I have is, have you looked at some models that are shunted hydrocephalus to see if these pathways still exist in the shunted model? versus just the, your obstructive model for hydrocephalus?
Yeah, so I'm pretty sure these pathways still exist. I know this from other people's work. If you look at some older papers, I'm pretty sure you're familiar with it. They looked at S100 protein in childhood hydrocephalus, and they showed that there is elevation of S100 protein in childhood hydrocephalus, even after they're shunted. So S100 protein is a little messy molecule. It doesn't always come from the brain, but I think it gives you an idea of that the elements of transport exist. And plus, we have never looked at shunted hydrocephalus, and our animal models have been rats. I know there are some people who have shunted, but you need a larger animal to look at them. But I'm pretty sure that these pathways exist based on what I have learned from the clinical literature. And thank you for your comments.
Thank you.
Thanks, George. Professor Deopujari, thank you.
I'm sorry, my connection was bad, so I missed some part of the talk, but it's quite interesting, and I know Dr. Satish is working on this for some time. I've heard him before, and I'm happy that he feels that the research has come to a stage where he can probably consider managing patients medically. Now, do we have a definite plan? I mean, do we have molecules which will enhance the, what should I say, CSF transportation?
Yeah, thank you very much. I appreciate your comments very much. And what we really know now is what not to do in terms of medications. Some of these, erythromycin especially, is used in pediatrics for improving appetite. And we have shown that the retrospective study actually came out of that observation in several children who got erythromycin had multiple shunt malfunctions. So we know that P-glycoprotein inhibitors, especially if there are more than one, will increase the chances of shunt malfunction. And we don't have a good inducer. We suspect that it's P-glycoprotein is not the only one that is responsible. There are multiple efflux transporters that are responsible. It's a complicated system. So we are actually in the process of looking at drug targets now and see whether we can actually enhance it. Our DoD grant was, part of that. And we did not find a great inducer yet, but I'm hopeful if we can, we have proven the concept that yes, it is probably macromolecules. Yes, we can manipulate macromolecules, but we have to get to the third step, which is improve the macromolecular transport.
Thanks.
Thank you, Professor Deopujari. Dr. Krishnamurthy, just, the recent paper in Nature on the CSF drainage into the nasopharyngeal lymphatics, and they mentioned about the use of, I think, ephedrine in one of the sympathomimetics, which opened up the drainage lymphatics. Do you have any thoughts on that?
I don't know. We haven't found a way to. That's not been our focus of our attention, to improve just the olfactory pathways. I suspect that based on the findings in our experiments and some of the other literature, I didn't go into details about traumatic brain injury and other literature where there is increase in the paravascular space that precedes hydrocephalus. So I think we have been focusing more on the paravascular pathways and looking at the blood-brain barrier as a modification, and probably choroid plexus, because they also have efflux transporters. It's different on both the sides. I haven't looked at sympathomimetics, and I don't know what effect does it have on the efflux transporters? So I did read that paper. It seemed like an interesting concept.
Thanks, thank you. Can I please bring Dr. Professor Ricardo Oliveira? Thanks.
Thank you, Professor Satish. Very nice, very interesting presentation. I have one question. Do you think that macromolecular clearance could be related with the genesis of normal pressure hydrocephalus in adults?
I don't know the right answer. Probably yes. Here is why I say probably yes. I think there is a close relation between Alzheimer's and other demanding disorders with NPH. And there is a lot of studies that have come out in the past, mostly from Europe than from US, where you take a biopsy specimen during the NPH, you see changes consistent with Alzheimer's disease, with plaques and tangles and other things, even in a small cortical biopsy. And I suspect that, if you have a failure of shunt to improve the symptoms in NPH, the brain is not actually doing that well. And if you look at the biomarkers in Alzheimer's disease or in NPH, there is a rise of the proteins in the CSF for a short period of time. And when they come down, they're actually devastated. So there's only so much protein and so many cells that can degrade in the brain. So I suspect it's the same, but I'm also not sure how much the venous system plays a role because most of these people have cardiac illnesses, and I'm not sure whether that plays into the ventricular dilatation, because NPH is also, there was a longitudinal study done by Pittsburgh, a guy called Longstreth et al. They published the relationship between cardiovascular health and the ventricular size. And they found that bad cardiovascular health will lead to less frontal lobe and more ventricles. And these people have bad cerebrovascular outcomes too. So this is why I say it probably is related, but I haven't done any work in that area.
Okay, thank you.
Thank you very much, Ricardo. I think that's a very, very interesting point that you make, Dr. Krishnamurthy, because at the moment we look at NPH, many people look at it as a matter of CSF drainage problem, but whether the CSF drainage problem is from accumulation of the proteins is an interesting area. So thank you very much for that point as well. So that's a great, now we look forward to learning from your research work in years to come. So thank you again, and good to know.
Thank you.
I think it's important for neurosurgeons to have a look at hydrocephalus in a holistic way, from basic science to surgery to neuropsychological outcomes. So great. Congratulations on your work. Thank you, sir.
Thank you very much. Thank you very much for allowing us to present our work. Thank you.
Thank you.